secondary pneumothorax. So as you can see here, patients came with symptom of breathlessness. You go down, so based on the algorithm, breathlessness is already an entry point to say that this patient would require an urgent chest drain insertion. So as is what happened to this patient, I would insert a chest tube and connect it to underwater seal.
Thank you very much. Thank you, Izrina. I would now like to invite our radiologist, Dr. Muhammad Imri, to share his slides and bring us through the HRCT of this patient.
Thank you, Prof. Andrea and Dr. Nik Nur Atika. Assalammualaikum and good morning, everyone. My name is Dr. Imri, a radiologist. So my topic today will be on pulmonary CT findings in lymphangioliomyomatosis or LAM. I will show you the HRCT that was performed for this patient. We'll have a look at this again later, but this is an example of HRCT of the thorax going from epiphysis to the lung basis. So before I talk about pulmonary LAM, I will just inform you guys about the definition of cyst or cyst-like lesions in the lung. So cyst is a non-specific term for a thin wall, well-defined lesion which contains either air or fluid. So when we are dealing with cyst in the lung, we are referring to air-filled lung lesions. Therefore, when we're dealing with cyst in the lung, the first step is to distinguish whether between a cyst and a cyst-like lesion, although some overlap may exist. These are the examples of lung cysts. The first diagram is a lung cyst. It's a well-defined air-filled lesion. It is rounded in shape. Next to it is a lung cavity. It has a thick, irregular wall. And also the next to it is pneumatocyl. Pneumatocyl usually is a result of trauma or infection. In this case, you can see it is a well-defined rounded air-filled lesion, and it is surrounded by ground glass opacities. So this is an example of pneumatocyl seen in infection. And in the fourth diagram is a bulle. So bulle is another cystic-like lesion in the lung. It is commonly larger than a regular lung cyst, and it is seen in subpleural in location. So if you compare the location of the bulle and the lung cyst, which is in intraparenchyma. Other forms of cystic lesions in the lung is emphysema. So emphysema is destructed alveoli and present as enlarged air spaces with imperceptible wall. So the most common type is centrilobular emphysema. Next is honeycombing. Honeycombing is the end-stage result of a fibrotic lung disease. It is a clustered layering of cysts, predominantly seen in the bibasal lung. And last but not least is cystic bronchiectasis. Bronchiectasis is a dilated, non-tapering airway, and the cysts are in continuation with these bronchi. This is a summary of what I've just talked about: the cyst, cavity, bulle, pneumatocyl, emphysema, honeycombing, and cystic bronchiectasis. We will have a look again at the HRCT thorax. So you can see there are multiple cystic lung lesion, which is symmetrical and distributed diffusely in the lungs. So the pulmonary findings in LAM or lymphangioliomyomatosis are cysts of varying sizes. They are round and thin walled. It is symmetrical and uniformly distributed throughout the lungs. And the complications of LAM, when the cyst ruptures, patient can develop pneumothorax or recurrent pneumothorax. And when the cysts are infected, you can have increased attenuation of the cyst, for example, in hemorrhagic cyst. And another complication in the thorax of LAM is chylous fluid effusion. Chylous means fluid from a leak lymphatic duct. So when we are dealing with diffuse cystic lung disease, there are a number of differential diagnoses. Apart from LAM, there is pulmonary Langerhans cell histiocytosis, centrilobular emphysema, and cystic bronchiectasis. in PLCH, Langerhans cell histiocytosis. In contradistinction with LAM, the distribution mainly is in the upper and mid zone and sparing of the juxtaphrenic recesses. And the intervening lung may have centrilobular nodules, and the cysts are bizarre-shaped cysts in comparison to a rounded, well-defined cyst. In centrilobular emphysema, the cysts have imperceptible wall and has predilection in the upper zones, while in cystic bronchitis cysts, there are tubular branching dilated bronchi, and the cysts are seen in continuation with the bronchi. Thank you.
Thank you very much, Imri. Now reshare my screen. So I think Imri mentioned chylous pneumothorax, chylous diffusion. So if you want to know more about it, please go to the Facebook website and look for our previous CPC discussion on chylous pneumothorax. All right. So probably I'll just pass it over to Dr. Nik Nur Atika to take over and further grill Dr. Isrina.
Thank you, Prof. So now you have the explanations from the radiologist that help us in terms of finding out the diagnosis. So most probably your diagnosis is correct in the beginning. So you said that this is patient had a spontaneous secondary pneumothorax with the cystic lung disease, most probably LAM, langiolaiomyomatosis. So at this point of view, what is your next investigations to add on or support your diagnosis further?
All right, thank you, Dr. Atika, and thank you, Dr. Imri, for the presentation. So actually, as Dr. Atika mentioned, as you can see, this patient has got 4 out of 5 typical pulmonary findings of LAM in the CT thorax, mainly a uniform distribution, thin wall cyst, spontaneous pneumothorax. Okay, so basically, the next investigation that I would like to actually propose, so basically, I mean, at this juncture, we think that this is most likely to be a secondary, spontaneous pneumothorax secondary to LAM. So as we might know, LAM is commonly associated with a condition called tuberous sclerosis complex, or TSC in short. So you can either have a sporadic or TSC associated LAM, but for this interest of time, so I would actually talk further on the TSC associated symptoms. So I would probably go through some of the symptoms or signs that I would be looking for if I would suspect, tuberous sclerosis in this patient. I will go from top to bottom. So basically, from the top, from the brain, I would take a further history. If there's any previous history of family history of epilepsy, history of seizure or intellectual disability. If there is if it's present, I would actually, or the CT brain or MRI imaging of the brain, looking specifically for some features such as cortical tuberous or subependymal nodule or some giant cell astrocytoma. And further down, I will look at the eye. So in tuberous sclerosis is commonly associated with retinal hematoma. So possibly I would refer to ophthalmologists for the expert opinion if there's presence of retinal hematomas. Bringing it down to the skin, so multiple skin lesion, actually associated with tuberous sclerosis, namely is a chagrin patches, there's an adenoma sebaceum or phageal angiofibroma in the face. There's also what we call as ash leaf spots, or it's actually a hypopigmented sort of macules on the skin. And also other organ manifestation as well. So further down to the heart, patient can have cardiac rhabdomyoma, patient can come with palpitation, cardiac arrhythmia, or even failure symptoms. And further down to the other organs in the abdomen, so kidney specifically, if you can actually recall back that this patient has got say they recall it as Worm's tumor, which we probably not really sure regarding the diagnosis. So, in patient with tuberous sclerosis, they commonly will have what we call a lesion called angiomyolipoma or AML. And some of the patient, can have a polycystic kidney disease as well because of the connection with the PKD1 gene. And some can have renal cell carcinoma, right? So in terms of that, because patient had a left nephrectomy in the past, I would actually want to look further into that. I would probably order ultrasound abdomen just to see if there's any evidence of a cystic kidney disease, let's say it's angiomyolipoma or even ADPKD at the kidney. But other than on examination, there is not suggestive of ballotable kidney, I can say. Yeah. And yeah, I think I think that's the investigation that I would order for this patient.
Okay, very good, Dr. Isrina. So you have done a lot of things. You revisit the history. So next, we did actually do a MRI brain for her, which revealed as a subependymal nodules. And also we did the ultrasound abdomen, which shows 70%, which show angiomyolipoma at the hepatic and also the renal. And also we did refer to ophthalmologists, and they can see the retinal hematoma there. So at this point, so we're also glad that we have a lung biopsy for this patient. So what is your, so let's see the lung biopsy of the patient and interpret, further clarify the diagnosis of the patient.
Thank you very much, Dr. Atika. So it gives me great pleasure now to actually invite Prof. Nurisma, our consultant pathologist, to actually go through the slides of this patient with us. It is quite rare to actually get a biopsy, so we're very fortunate. I would now like to invite Prof. Nurisma to share her slides if she wants to, depending on the mood. Okay, click. Slideshow, please, Nurisma.
Yeah.
Okay, as we wait for Prof. Nurisma to put on slideshow, I hope that you haven't lost.
I cannot remove this icon at the top of my laptop lah. Kejap, slideshow.
Just put enable editing. You click on that.
Enable editing. Kejap. Okay. No, I cannot remove the.
Never mind. Then I tell you what. Shall I share your slides for you?
Yes, please. Thanks.
Okay, no problem. I'll taking over. Can you stop sharing, please?
Okay.
Okay. All right. I'll share. So this is just to show you that we have a good relationship with our pathologists. Is give and take, and that's why we get on well in UKM. Nurisma, don't run away. I'm not going to show you.
No, I'm not running away. Switching on the fan.
I get so stressed. All right. Okay, I'm going to move to the next slide. When you want me to move to the next slide, just say next.
Yes,
right.
Yes, sure.
Okay, so this is the right.
Okay. We received this one fragment of brownish lung tissue, which with the following measurement, which is about 3 by 2 centimeters by 1 centimeters size, and then cut section shows there were 2 bullae, which are all both are sub centimeters, and we took 2 representative sections from the tissue. Next, please. Okay, this is a low-powered view of the lung biopsy, which show. Can you see my cursor?
No, because I will have to move the cursor for you.
Okay. So you see the large air spaces at the center and the much smaller one around the periphery. So they are basically thin-walled cystic air spaces and they are patchy disordered. They are not like uniformly distributed throughout the biopsies. And I suppose this appearance is in keeping with the radiological finding that was shown just now. And there are, if you can appreciate, a smaller clustered to nodular proliferation of the bland spindle cuboidal epithelial cells, which is better appreciated on the much higher view which I will show later. And these are mainly seen around the airways, lymphatics and blood vessels. Next, please, Andrea. Okay, so here is a higher view of the lung, and it shows here the cyst wall that are lined by the alveolar and the bronchiolar epithelium. You can move your cursor towards the, yes, that's the one.
Oh, that's it.
Okay, you're very good in histology. Okay. You can take over my job. Okay, so this is just to highlight the histology of the lung. Okay, next, Andrea. Probably undergraduate stuff, and here is the much higher view of the lesion of the area at the center there, Andrea. Yes, that's the one. These are the area where there is the nodular proliferated cells lah. Okay, this is a times 14 magnification. Next, Andrea. Okay, okay. Here you can see the spindle cells which are located centrally with the peripheral more epithelial looking cells. Okay. Not so exciting lah, this biopsy, but there's something there, you know. Maybe for us it's not so exciting, but there's something there. Okay, so next please. So with this we proceed to do immunochemical studies, and this here shows the epithelial cells are positive for HMB45. Okay, and you can see that patchy. The area positive, some area positive, some area negative. Okay, are not that it's not diffuse. It's not like lining positive. You are not looking at something that is so diffusely positive as you will see in the SMA staining later on. Okay, next, Andrea. Okay, now we also do Desmin. Before I forget, the HMB45 is a immunomarker that we normally use to diagnose or to confirm melanoma cells. Okay, but it can also be used to stain, to highlight or demonstrate the perivascular epithelial cells, which are usually present in this condition. Okay, so Desmin is a muscle is an immunohistochemical marker that we use to stain skeletal muscle. Okay, so it is usually skeletal muscle, smooth muscle, or myogenic differentiation. Okay, so here the Desmin is positive, weakly positive. The brownish areas are positive. Not so great looking here, but they are positive, I can assure you. Next, Andrea. The next marker that we do is the smooth muscle actin. Smooth muscle actin is immunomarkers that we use, which will normally stain the smooth muscle cells and the myofibroblasts. Okay, so here here again the smooth muscle stains this. It stains all the smooth muscle component of the nodular area lah, of the proliferated area. Okay, next, Andrea. Okay, with this, with the clinical history, with the radiological findings and histological findings supported by the immunohistochemical findings, our interpretation is the lesion is consistent with pulmonary lymphangioliomyomatosis. Next, if there is any,
I think this is your last slide.
This is the last one. Yeah. Great.
Thank you very much.
So basically,
I'm glad I passed the exam, that I managed to point the cursor at the right place.
Okay, thanks. Okay, thanks. I'm glad I sent you the slide. Okay, thanks. Thanks, Andrea.
Yes, prepare for the worst. All right. So one question to Izrina at this point. So many people have told you over and over again. So what is your diagnosis?
Right, so my full diagnosis for this lady would be a secondary spontaneous pneumothorax, secondary to underlying lymphangioliomyomatosis.
Okay, so very good, Izrina. So we have a diagnosis already with a multidisciplinary team involvement. So we see the progress of the patient. So patient, of course, we did the ultrasound, we did the eye assessment, lung biopsy also revealed by Prof. Norisma Lam, the diagnosis, and inserted the right chest tube, which Dr. Izrina mentioned before. However, this patient had a slow lung expansion and persistent air leak. So because of that, we did a medical fluoroscopy of the right lung, but it turns out to be failed. So our cardiothoracic surgeon to help us in terms of pleurodesis, surgical pleurodesis, and also VAC splectomy. And unfortunately, patient was discharged well with the lung rehabilitations. Yeah.
So I probably now like to invite our cardiothoracic surgeon, Mr. Hisham, who's also head of cardiothoracic. I will be controlling his slides. So if there's any problems, don't blame him, blame me. Okay, Hisham, you may talk now.
Okay, thank you so much, Dr. Andrea, Dr. Tika. Assalamualaikum warahmatullahi wabarakatuh. Can everybody hear me well? Yeah, thank you so much for the rescue team for inviting me to discuss a bit more about the patient's patient surgical intervention for this patient. Next slide, please. Next. All right. Basically, thoracic surgeons in this particular disease came in because of two things. Number one is acute management, and number two is long-term management. And acute management, basically, when there is number one is respiratory failure, we can put patients on ECMO, and number two, with other complications like these patients, pneumothorax with persistent pneumothorax, and other complications in such patient in LAM is another one is chylothorax. Then a long-term management for this patient, surgeon can do a lung transplant, and we know that lung transplant has a very limited role here in Malaysia, but there is a role for lung transplant. So the first complications that occur in this patient is pneumothorax. Well, it's more than 40% patients presented with the first presentation, and 66% of patients during the course of diagnosis, when the estimated recurrence rate of LAM is 75% after the first episode. Dr. Nur Izrina put the chest tube in and conservative management for pneumothorax, but unfortunately some fistulation hasn't occurred, and we have to do some surgical intervention, including VATS intervention and also pleurolysis. I will talk more on chemical versus surgical pleurolysis afterwards. And in the literature, it shows that there is also a recurrence rate post-pleurolysis. It's about 18 to 32%, and more of the recurrence rate is in the chemical pleurolysis, lesser than surgical pleurolysis. As Dr. Imri said before, one of the complications for LAM is chylothorax, which occurs 7 to 10% of patients. The pathological cause for this is number one, obstruction of the thoracic duct and its tributaries, leakage from pleural lymphatics, and transdiaphragmatic flow of chylous ascites. As previous CPC, Dr. Prof. Andrea, we have discussed more about the conservative management for chylothorax. That is put on free diet, fat-free diet, supplement with change triglyceride, medications with autotite induction, the chyle formation. And we're looking at the literature. If the accumulation is small, we can do thoracosynthesis and pleurolysis. But if the accumulation is recurrent and large amount, so there is a role for surgical intervention. There is a ligation of thoracic duct, and this can be done by VATS or thoracotomy. Interestingly, there is a increased evidence of success in reducing chylothorax by giving sirolimus therapy. This is with or without any surgical intervention. Next slide, please. So I have said before, the long-term management for patients as very bad lung disease, as such this patient, one of the treatment is lung transplant. The first transplant is in 1983 and only reported in 1985. It is recommended by both European and also American Thoracic Society that patients with progressive disease, severe disability, oxygen dependent, and hypoxemia at rest, and other recommendations is very bad lung function impairment, as I showed here. While there is no contraindication for transplant post-pleurolysis, we have done a pleurolysis for patients not to have a recurrence of a pneumothorax. There is no contraindication for it, but it will have some increase in morbidity, such as bleeding and also infection. The survival for this patient is for lung transplant is about 75%, as high as 75% in the Japanese data. Next. I have asked to talk about VATS. That is a video-assisted thoracoscopic surgery that we had done for this patient. And the recent advances for VATS that we can do majority of thoracic surgery procedures via VATS. Okay, from a simple biopsy, from pleurodesis to major dissection to the lung, major dissection to the mediastinum, including thymectomy. With a single port, multiple port access to the thorax, we have to do a single lung ventilation. For this patient, we have to put a double lumen tubing, so isolate the right side and the left side. But we have to give just enough pressure to ventilate the patient on the left side. This is because we know that there is a lot of cysts. The left side also is very bad parenchymal disease. We did the surgical pleurosis for this patient, and there is a debate on either chemical pleurosis first or surgical pleurosis first, and the European suggests chemical pleurosis in the first pneumothorax. If no response, recurrent pneumothorax, which is appropriate surgical intervention to be done, as like Dr. Natika and the recipe team referred to us. But there's a lot of papers saying that for such disease, for diffuse such disease, chemical pleurosis will have a high recurrence rate. So after the first pneumothorax, straight away put some surgical intervention. We did a pleural abrasion for this patient, parietal pleural abrasion for this patient. We rubbed the parietal pleura with a very coarse diatomic cleaner. So we abrupt, make it bleed for at the parietal pleura. And some of us mix with the chemical. So in our center, we also mix chemical and also surgical pleurosis. We mix talc directly onto the pleural space and put as antibiotics. There's a new technique, actually. There is some techniques that will increase the success and reduce the recurrence of pneumothorax. That's called total pleural coverage. There's a new technique which is using oxidized regenerative cellular mesh. We wrap that mesh around the visceral pleura, so it will have lesser recurrence. Another more aggressive is total pleurectomy. So we have a lot of adhesions post-pleurectomy. And this total pleurectomy is in the literature has increased in mobility for lung transplantation. Next, please. As I said before, there's in role of surgeon in acute very bad acute respiratory failure is putting in ECMO. ECMO is extracorporeal membrane oxygenation, and it's being used essential for cardiopulmonary failure patients. There's two types: veno-venous, mainly used for respiratory failure patients, and veno-arterial in keeping with cardiac failure patients. Using in interstitial acute respiratory failure in interstitial disease such as LAM is well established, and since the starting of using of ECMO. And there is increased data using ECMO as a bridging procedure for lung transplant. As you know, the ECMO can be used like 2 weeks, 3 weeks with some complications. And there's a bridging period for waiting for lung transplant. This is just an illustration about the VA ECMO, putting directly in the right atrium and also the aorta. Another procedure is peripheral circulation using the femoral artery and femoral vein. Another one is at the neck using jugular vein and axillary artery. That's a bit of some of the ECMO that can be used for in acute setting for such patients. I think that's it. Thank you so much.
Thank you very much, Mr. Hisham. I would now like to, so I think Mr. Hisham is the person responsible for the big chunk of tissue, and that's the reason why we got a good biopsy that Prof. Norisma could read. So well done, Mr. Hisham. I'd like now invite our physiotherapist, Puan Surya, to show us from the physiotherapist point of view, a patient post-VATS, a patient with a lung function that's not that great, probably deconditioned, what she can offer. Thank you. Ms. Surya.
Okay, I share my slide, okay?
Yes, please.
Can hear me?
We can hear you loud and clear. So I think physiotherapy is a place that's always neglected, right? While she's getting her slides ready, we'll probably just say that a lot of us always stop at the cardiothoracic point of view, and then we think this is all that we can offer the patient. So I think this is to actually explore the options that we can have in pulmonary rehab. I think we're one of the few centers in Malaysia to actually have a pulmonary rehab first, right? So it's good that we know what type of exercises that Ms. Surya can actually offer to us. And I don't know whether how many of you know where the physiotherapy place is. Maybe you can put in the chat whether you know or not. You can get some marks for it. I think Dr. Atika will give you some present if you get it right. I'm sure a lot of us don't know what level, whether it's actually level 1, 2, definitely not 3, 4, 5, 6, 7, and so on and so forth. Okay. So as in any presentation, there's always a little bit of technical issues. We welcome that because it gives me
that
talk.
Wait, I need some help.
So maybe we'll just, while she's doing that, we'll talk about, I think, Dr. Hema says basement. Okay, Hema, coffee on me when you next come to UKM. So I think, we talk about vets very easily when Mr. Hisham mentioned it, but actually in reality for this patient, it was a little bit difficult because you can see that the lung was totally diseased. And what happens is when you actually want to do vets, you have to do single lung ventilation. Isn't that right, Mr. Hisham? So the worry that...
yes, there's a rule. We have to do single lung ventilation for any surgical intervention for vets. As I said before, to isolate. It's a bit difficult because of interstitial disease for the other part of the lung is quite bad also. So we do not want to exert more pressure, and then we'll avoid pneumothorax on the other side. So during the surgery procedure, it's very crucial for the cardiac anesthesia to do this.
Yeah, so I think the other thing would be in terms of lung transplant. I think a lot of you probably think, what does this patient require lung transplant? So that's a good point that Mr. Sham brought up, the indications of lung transplant. Everybody wants to jump on the bandwagon and say, oh, we refer the patient for transplant. I think first and foremost, the patient must be symptomatic and must be on oxygen therapy. So otherwise, it is the blanket rule would be they need to be symptomatic at least. If they're not symptomatic, the lung transplant itself is a huge operation. It carries morbidity and mortality, so you wouldn't subject the patient to that, right? So I think this patient, when we presented, it appears to be very smooth, but she had a very prolonged stay with us. And I think cardiothoracic and respiratory were in close communication because, and with the anesthesiologist as well, because she had multiple recurrent pneumothoraces. I think Mr. Hisham brought up the chemical fluidisis is not very useful, which is true. The site that we did chemical fluidisis, she went on to have another pneumothorax. So she had the most chest tubes inserted in her lifetime during her stay in medical 2. That was back in the dark ages when I was still training and not very smart. If she were now, I think we probably would have managed her much better, lah, kan? Right? Okay. I think very interesting talking about the lung, the extra pulmonary manifestations that she has, right? So we don't have the MRI because the MRI initially was done in another center, and the person was not too keen to share it with us. But it was reported that she had subependymal heterotopia. So you know that patients always, we kept asking the patient whether she actually had any seizures, and I think Dr. Izrina mentioned in terms of a mental capability. So this is a young lady with a higher intellectual. She's not affected by her subependymal heterotopia. She has no seizures, and she's actually quite intelligent, right? So she's actually managed to graduate and go on working. Surya, may I have an update of your slides? Otherwise, can I just invite...
Okay, Prof. Andrea, can you hear me?
Yes, we can hear you.
Can you hear me very well? Okay, sorry for the technical problem.
We can't see your slides yet.
Okay, hello, Assalamualaikum everybody. Thank you to Prof. Andrea to invite me to present for today regarding pulmonary rehab. So I am Puan Surya, a physiotherapist for our hospital, HCPM. Today I would like to share about what physio can offer to pulmonary rehab program. So here is, we can share our location at the basement.
I think your Surya, sorry, your slides are not. I think we can't see your slides yet.
You can see my slide.
No. You have to click on something. I'm not sure because. Bila share kena pilih window. Yep. You know when you share, you have to pick the window that you have actually opened your slides on. So now you're sharing your desktop, I think. Yeah.
Okay. You share?
Yeah, can you stop sharing first and then you reshare? Yes, that's right. Excellent. Okay, good. Right. Okay, now we can see your slides. So if you can put it on slideshow and then we're good to go. Nice pictures, I see.
Okay ni. Tolong cursor ni kan. Okay. Okay, now Prof. Andrea, can you see my slide?
Yeah, maybe you can skip the few slides and show us the pictures alone because we are running a little bit short on time. Is that okay? Okay, all right. Thank you, Surya.
Okay, may I start now?
Yes, you may start now.
Okay. Assalamualaikum. I am Puan Surya from Physiotherapies. Here I want to share my location of our unit. We are at basement. The second picture is our gym, performance gym, and this is our gym. Okay. Pulmonary rehab is a safe intervention and improve exercise capacity, dyspnea, daily physical activity, quality of life, and muscle strength in LAM. Okay. Our pulmonary rehab program consists of supervised exercise, which have twice weekly, and our session is 1 hour, and the duration of our program is 8 to 12 weeks, and it comprises of endurance, strengthening, and stretching component. And then patient education we also give, and then we teach about physiopathology and treatment, self-management, exercise physiology, and the importance of physical activity. So normally the outcomes we use is to assess patient dyspnea. So normally we use box dyspnea scale and modified medical research council dyspnea scale. For box dyspnea scale, normally we use during before exercise, during exercise, and after exercise. While modified research medical council dyspnea scale, normally we use during to describe patient current performance lah. So the grade is 0 to 4 for MMRC. So kalau 0 ni, I only get breathless with strenuous exercise. 1, I get short of breath when hovering on the level or walking up a hill. 2, I walk slower than people of the same age on the level because of breathlessness, or have to stop for breath when walking at my own pace on the level. 3, I stop for breath after walking about 100 yards or after a few minutes on the level. 4, I am too breathless to leave the house, or I am breathless when dressing. So if we use MMRC score, we can assess patients' dyspnea by weeks. While dyspnea scale, we can box dyspnea scale, we can assess patients during exercise and also during tests. Okay, this is 6-minute walk test to assess performance test. So what is the importance of 6-minute walk test is we can see patient level of endurance and we can see any desaturation episode during the test. And then the 6-minute walk test also important to us to prescribe exercise or walking exercise and also cycling exercise, to give to the patient the intensity and how long that we need to give to the patient, 10 minutes, 15 minutes or 30 minutes. So we depend on patient condition. Exercise prescription, normally we use, we require this item: intensity, duration, frequency, type, mode, and progression. The prescription for each patient should be based on his or her level, result from tests of exercise capacity and strength. So for example, after we check 6-minute walk test and then we prescribe the exercise for walking. So the intensity is, normally we use a moderate intensity for pulmonary rehab patient. So duration, maybe 10 minutes, can be 15 minutes, can be 20 minutes, can be 30 minutes, depend on patient performance and patient condition. And then the frequency means that how often when a patient needs to do exercise per day and how frequent that they need to do exercise per week. So type is interval or continuous. So mode is walking exercise. So we can progress the patient walking exercise by increase the patient duration and also increase the frequency. This the example. This is exercise training that we give to the patient. A pulmonary rehabilitation program must include lower limb and upper limb endurance training. So endurance training such as brisk walking, walking on treadmill, cycling, step exercise is the lower limb endurance training. And upper limb we can use ergometer, but here no ergometer, so we use dumbbell with lighter weight. So we increase the repetition, but with the light one. So we also give patient strengthening exercise. We can use dumbbell and one station gym. This is for back exercise, and then for our latissimus dorsi, okay, to strengthen the upper limb muscle as well. So this is stretching and flexibility exercise that we give to the patient. Normally we teach the patients and then we ask the patient to do at home, and we will review the exercise during the next session. This is the prescription, how we calculate walking and treadmill exercise by using 6-minute walk test. So normally we take 80% of 6-minute walk test average speed. 6-minute walk test average speed means that 6-minute walk distance times 10 and over 1,000. For example, if patient can walk 300 meters, we times to 10 and over 1,000. So we get 3 kilometers per hour. So from 3 kilometers per hour, we only take 80% of it. So patient, if we prescribe to walk on the treadmill, we prescribe to use 2.4 kilometers per hour. The minimum, the starting point for progress, the exercise.
Surya, can we move on a bit faster because we are a little bit short of time. We have Dr. Atika as well.
Okay.
So maybe you can show your video and then we will end with that.
Okay.
Is that okay?
Okay, this is my video.
I think we will stop here, Ms. Surya. Yeah, thank you very much. All right, great. Okay, so can I ask you to, okay, thank you. Can I ask you to stop?
That's all.
Thank you,
On
Ms.
my side.
Can you stop sharing so I can share? Can you stop sharing, Surya? Okay, great. Okay, thank you. So I apologize, we're running a little bit behind, but it's through no one's fault in particular. So it gives me great pleasure to now invite Dr. Nik Nur Atika Nik Abid, our respiratory fellow, the person who is together with Dr. Boon solely running the respiratory unit at the moment. She'll go through the case summary, learning points, pneumothorax, very important students. It can come out in exams. And in terms of multiple cystic lung disease, it can come out in Masters of Medicine.
Okay, so we summarize the case. A young woman presented with secondary pneumothorax with multiple cystic lung disease, which show associated with the renal, hepatic angiomyolipoma, and also retinal hematoma. And the lung biopsy also showed the LAM features. So what is actually LAM? So LAM is actually a rare disease, a progressive cystic lung disease. So it's affects young females. Just like what Izrina mentioned, it's associated with tuberous sclerosis. And then common presentations, all the speakers has informed, which is pneumothorax and chylous effusion. Sometimes it's extrapulmonary manifestations such as the angiomyolipoma. And of course, with the help of Dr. Imri, HRCT thorax showed the diffuse thin wall cystic lesions showing the LAM. So why this patient was not diagnosed as a tuberous sclerosis complex? You see that to diagnose, we have to have a definite, the major criteria, which is 2 major, but this patient had only LAM plus angiomyolipoma. But these 2 major features does not meet the criteria of definite diagnosis because there's no other features. So we call it as a forme forte. So clinical features suggestive TSC, but not definite diagnosis. Okay, the treatment will be, of course, lung transplantation, such as what Mr. Isham said. This is the options, but we have another medications, which we call it a mTOR inhibitor, which can actually effective in terms of reductions in improve the lung function test, especially forced vital capacity. But the side effect, of course, we can have an oral ulcer, diarrhea, and infections. So that's all from us, the point of view of the LAM. Okay. So we're back to the chapter 6.
Moderator.
Sorry, moderator.
Okay, thank you very much. Now I'd like to pass to Encik Buhari. We have actually submitted some questions for Kahoot for the students. The highest marks will be announced, and please come to the respiratory lab on the ground floor to collect your present. Thank you. Encik Buhari. So students, please remember you have a very small, we are cheap people, so you get a small present, but it's a token of appreciation for for attending our CPC today. Right. I'd like to thank all the speakers for your slides. Sorry, I had to cut you short, Surya. Oh, and Dr. Atika has got presents for the speakers as well. So please claim it from her later. Sorry to update, otherwise there'll be just update. Edit.
Okey, tunggu sebentar. Saya adjust dahulu.
Okay, it's like glitch in the system from Encik Buhari. I think it's Kahoot normally can have more people, right? So if just only 3 of you, that would be incredibly sad. Yes, yes. So I think for the medical students, I hope that you kind of know where to go, guidelines in terms of pneumothorax. Please don't mention LAM as your diagnosis of pneumothorax straight away, as right? So because for CPC purposes, we present interesting cases, but other common causes should be considered. Infection is one of them. We have seen, as Izrina mentioned, patients with smear-positive TB who present with pneumothorax. Right, so infections common. So I'm not sure how how long it will take to upgrade the Kahoot, right? So not sure about it. Hopefully Encik Buhari is the credit card.
Andrea, can I ask you a question?
Can.
Is it important for the patient to be seen by the neurologist regarding the tuberous growth, whatever finding in the CT scan?
Not necessarily, because these are lesions that are there. So ideally, if they come to us and they have, when we screen them, we should do either a CT or MR. And this patient the initial screening was done in a separate center and done by a general physician, and they managed to pick up a lot of things. What goes on beyond that, I think would depend on whether she actually has got symptoms or not. If she had seizures, then yes, she would be better managed under neurology, but she did not.
So neurological wise, she is asymptomatic, well and fine.
Yes, correct. That's right.
Thanks.
Okay, no problem.
Oh, sorry, Andrea, one more question, sorry. What's the prognosis for this girl?
Okay, so I think it's a good question. If you have a look at the Imri showed the CT scan, we can see that from little normal lung. So in terms of the progression of disease, the progression is actually mainly in the lung because of the expansion of the cyst. So her prognosis wise would depend on how fast the cyst actually enlarges. So that's the reason why Atika brought up the mTOR inhibitor, which was I think was in a randomized controlled trial. It was a landmark study which showed that by using sirolimus, you manage to actually decrease the decline of the forced vital capacity. They did not not image the patient back again because that wasn't the role. But in our patient, because I do a lot of things that are, so I actually repeated the images. The lesions, some of the lesions from my eye, not Imri's eye, actually became a little bit smaller. So I think that there is some, if anything, it gets to halt the disease. So if it doesn't work, what happens is that she will become more symptomatic. She will become oxygen dependent. She would then fulfill the criteria for lung transplant. So actually what we did was we preempt, right? So you don't wait for her to need the lung transplant and then be on the list. So I think what was not mentioned by Atika in the shortness, because it's not enough time, but now we have so much, so I'll tell you more stories, is she's actually been referred to Hospital Serdang and she's been put on the transplant list. I suppose Mr. Isham will say, with the pleurodesis and all of that, if you look at the books, it's a relative contraindication to lung transplant, absolute contraindication. Currently, she's not oxygen dependent, but her MMRC is about 3, so she is symptomatic. Yeah. Does that answer your question, Prof. Nurisma?
Yes, thank you.
So I get full marks. Huh?
Of course, always.
More than people, I hope. Okay, Bu Hari. Oh, good. Okay, all right. Yeah, well done. Thank you very much. Will the winner, I know you're shy to identify yourself in the chat group, but can you please come to the Respi lab and look for me? Semua student urge to update. Oh, okay. All right. Oh, this one. Present. Okay. Okay. Scan MMA. Okay, let's scan for our points, MME. Otherwise. So thank you everyone for attending the CPC. You may now leave. The student yang dapat top marks tu, please come to the respiratory lab, Makmal Perubatan Clinical Respiratory on the ground floor. And I think Encik Buhari also urges us to fill in the attendance, otherwise you won't get your jumlah jam latihan UKM. And then you'll be running into trouble for your SPPU and my KPR. So I think for the speakers, if I can ask you to stay back, because we went through this harrowing, we would like to take a group shot. Okay, once we are off live on Facebook. Excellent. I don't care.